Hello there. Thank you for the kind invitation to speak at your Indonesian Vitreoretinal Society 2021. Apa khabar? I'm going to be speaking on advances in surgical treatment of stage 4 retinopathy of prematurity. I am based in London. I'm the head of the ROP Retinal Detachment Surgery Centre, the UK de facto national centre at Great Ormond Street Hospital for Children. I also work at the other following hospitals in London. Here are my financial disclosures. I'm a consultant to DORC as well as Viva Visitech that makes the endoscope. So here is a summary of the stages of ROP at when there is stage 3 disease with plus, that is when laser or anti-VEGF is done, and about 5% of cases go on to develop retinal detachment. So stage 4A is macular sparing, stage 4B is macular involving detachment, and stage 5 is total detachment. Before we discuss the management of stage 4 ROP, retinal detachment, I'd like to share the natural history of untreated retinal detachment. We have data from the ROP study done in the 80s and 90s with RCT data. There was a subgroup of patients that had retinal detachment that were observed that did not have any treatment, and this is what happened with them. So in the stage 4A with macular sparing detachment, 92% went on to develop unfavorable outcome. This was seen in 39 eyes with 4.5-year follow-up. Once they get to stage 4B, when the macula is detached, 82% end up with perception of light or no perception of light vision. Therefore, the outcomes are much worse. And this is what we really want to prevent, stage 5 ROP, because almost 80% of these eyes end up with no perception of light vision with 5 years follow-up. The key challenge of ROP surgery, in my experience and the experience of others, is preservation of the lens during primary vitrectomy. And that is really important because it has a significant impact on the outcome of the patient in the short and long term, as well as the risk of complications. So it has been shown that lensectomy is required during primary vitrectomy in 57% of stage 4 ROP cases, and depending on your case selection, this may be an underestimate. And this is important because this increases the risk of glaucoma. So in the medium term, in this study, they showed an odds ratio of almost 8.8, so 8.8 times increased risk of glaucoma when lensectomy has been done. This is with 24 months follow-up. There's another study with 3 years follow-up, again, an increased risk, a hazard ratio of over 3 in 400 eyes of developing glaucoma. What about the long term? This study of 407 eyes over 15 years showed that patients that had lensectomy are at significantly increased risk of developing ocular hypertension. In addition, there are implications on amblyopia, on postoperative visual rehabilitation. If you're having to remove the lens and render a patient aphakic, you'd have to patch the patient. One may have to consider contact lens use and potentially secondary intraocular lens implantation, but not before 2 years of age due to the risk of glaucoma. So lens removal during ROP surgery is required potentially in 2 scenarios. One is when it's planned. So this is when it usually occurs, and planned lensectomy is done to enable safe access into the vitreous cavity with your vitrectomy instruments, because the eye is really quite small, and I'll show you some images in a moment of why this is an issue. It can also, in unplanned cases, when there is damage to the lens during vitrectomy, so iatrogenic lens trauma, that could cause a visually significant lens injury. So what is the impact of lens removal on vision? Well, the analogy that we have is congenital or pediatric cataracts. where it has been shown that the impact on visual loss is much greater in kids that develop cataract at 4 months or younger. Now, considering our ROP babies are premature, by the time they come to have vitrectomy surgery, the impact is likely to be similar as a child who developed congenital cataract at the age of 4 months or less, as opposed to infantile cataract that develops beyond 4 months of age. Therefore, the impact of primary lancectomy during primary vitrectomy is high and is significant for the development of deprivational amblyopia. So to prevent lens removal during ROP vitrectomy, one has to consider both the normal anatomy and understand the pathology in ROP retinal detachment, which is very different from other forms of adults vitreoretinal surgery. So in terms of normal anatomy, the ocular growth plateaus at age 2, and therefore the highest risk of lens injury is in the youngest patients. In addition, when you look at the anatomy, whilst the axial length in a newborn child is 75% of the adult eye, pay attention to the volume of the posterior segment. It's 20% of the adult volume. Therefore, the space in which we have to do surgery in these babies is really a lot smaller, and there's a higher risk of lens injury or damage to the retina. Here's an example of a child that we treated at Great Ormond Street Hospital at 24-weeker. There's now 42 weeks post-menstrual age with a 4B retinal detachment in the left eye. These are RetCam images, and you can see that the image on the right, the lens is focused at the highest point of the retinal detachment, and the posterior pole is completely out of focus. That demonstrates how highly elevated the traction retinal detachment is and how close it is to the lens. So how do you manage such a case? Well, there are a couple of intraoperative challenges to consider in ROP retinal detachment that's unique to this condition. Firstly, there's very anterior traction retinal detachment, as we've seen, with anteroposterior orientation of the traction pulling the retina up towards the pars plicata, the lens, and the anterior hyaloid. So this means that the space for a safe sclerotomy to avoid damage to the retina is the risk of injury during a sclerotomy is much higher compared to a standard adult case. So it's risky. Even standard sclerotomy is risky. In addition, there are multiple vectors and layers of traction that emanate from the original ROP stage 3 ridge. And it's important to be able to identify all these vectors of traction and do appropriate vitrectomy to relieve that traction to achieve maximum anatomical success. So coming back to this child I showed earlier with the 4B detachment that's highly elevated, the image on the right with the posterior pole out of focus. What are the management options? Well, firstly, you could consider encirclement. We don't really do that anymore because encirclement only addresses the anterior posterior traction as shown by the blue arrow, but all the other vectors of traction shown by the red cross are not addressed. Therefore, vitrectomy is the treatment of choice, but I've already highlighted that creating a sclerotomy safely is much more challenging in these babies. And if you do create an iatrogenic retinal break, it has been shown that up to 100% of cases end up with total retinal detachment and phthisis and failure. Therefore, we want to avoid this at all costs. So the trade-off then is sometimes if you are concerned about creating an iatrogenic retinal break is to sacrifice the lens, therefore do a primary lensectomy, which is required in 57% of cases, but it leads to worse outcomes that we've discussed, glaucoma and amblyopia. So the treatment that I use, the approach that I use is an endoscopic vitrectomy approach because it has two unique surgically relevant properties that improves the visualization of ROP-specific pathology. So the first property is that the surgeon's perspective is different. So rather than a bird's eye view, like the image on the left with the standard microscope approach, the view is as shown on the right from where the endoscope sits in the vitreous cavity. So the light comes from the endoscope and the image is reflected back into the endoscope, and you view the image on an LCD screen. So you have a very different perspective. Secondly, with the endoscope, it uses coaxial or reflected light, as I've just alluded to a moment ago, compared to transmitted light with a microscope, and therefore you can see some of these vectors of traction more readily that can be helpful for optimizing surgical outcomes and relief of traction. So back to this case that I've already shown. So what we did was that using the endoscope, this is the endoscope view. At the top of your screen is the normal lens, which looks gray with the endoscope view. We're looking at the pars plicata. That's a 23 gauge MVR blade that's being guided carefully with direct visualization using the endoscope between the tight space to clear normal lens at the top and the traction retinal detachment is coming up towards the lens. And this narrow gap that we can directly visualize with the endoscope, we can then create this sclerotomy safely. Without the endoscope approach, one would have to consider sacrificing the lens because you can't take the risk of damaging retina. So this is that patient 3 weeks on. The bottom images show gradual resolution of traction retinal detachment with a successful outcome. Here's another high-risk patient, an ex-ROP patient with a left eye that has total inoperable detachment with phthisis. So the right eye has a macula involving traction retinal detachment. It's a 4B, and you can see that there is significant traction because there is macular heterotopia with the macula rotated infratemporally. So you can see the traction in the bottom left there, and these are the endoscope guided images showing sclerotomy formation. On the left there, you can see I'm attempting to create a sclerotomy, and the tip of the MVR blade is pushing against this white tissue, which could potentially be a mixture of fibrosis and retina. So the endoscope allowed me to identify that. I was then able to reposition my blade half to 1 clock hour away. And as you can see, I am now safely in that zone through the pars plicata between lens and retina. And I've been able to preserve both lens and retina with confidence. So in the UK at our national center, we use a unique approach of simultaneous endoscope and microscope visualization. The benefit of this is as shown. So on the bottom left is a microscope view of a 4A detachment. And I really like this video because the endoscope view on the top right that shows the multiple vectors of traction emanating from the original ridge. And if you can see that very clearly, then you can shorten your vitrectomy time because you know exactly what you need to cut and where to achieve retinal reattachment. Here's another case, 26-weeker, 870 grams with bilateral 4A detachment. So the macula is spared. Now, what's interesting about these cases is that when you have a macula sparing detachment, you would expect these patients to have a reasonably good outcome because the macula is uninvolved. Now, with this patient, the traction was really quite peripheral. You can see with the endoscope view there on the right, we're looking at clear lens at the top. The vitractor is near the pars plicata, and the traction is like a curtain draping over the pars plicata and obscuring the pars plicata. So the access to the area is only possible if you remove the lens through a standard approach. So a microscope view, you can't see that area, whereas with the endoscope view, you can see now I've managed to safely remove that curtain of traction, and the pars plicata has now been revealed, it's now visible, and both the retina and lens are undamaged and preserved. So we've been able to prevent primary lensectomy in this case, which you would have to do if you're taking a standard microscope approach. Here's another example of a 4B detachment with traction retinal detachment coming up very close to the lens and anterior hyaloid face, attached to the anterior hyaloid face. And the endoscope view allows us to see exactly what the relationship is between the scissors here and the lens, so I could cut through the fibrosis without damaging retina or lens. With the microscope view, you don't know that you're touching the lens until you actually hit the lens because the lens is clear. So I'd like to share with you our UK data. We've been doing this since October 2014. So it's actually been over 6 years now. This is a consecutive non-comparative surgical series. We have 3 consultant surgeons as shown here. My colleagues, Drs. Patel and Henderson. This is data up until September 2017. So there are three categories of patients. Stage 4A is macular on or macular sparing, 4B is macular involving, and 4B5s are patients where there is a total detachment except for the anterior rim where laser has been done. So it's more severe than your typical partial macular involving detachment. So this was a consecutive series. We did not exclude any patients. So the technique is as shown. We use a dual visualization technique with the endoscope and microscope. The step one is using an MVR blade, as shown 23 gauge MVR blade. And this is an approach that I really like. And Doc is the only company that has a two-step trocar insertion technique. And the reason why I use two-step trocar insertion technique is because you see in the next step, we're using a blunt-ended microcannula to introduce the blunt-ended trocar to introduce the microcannula and to attach it to the sclera, to put it through the sclera. And you can see even as we are, I'm sliding this through the sclerotomy that's already been pre-created with a 23 gauge MVR blade, I'm having to push on the sclera there because the sclera is quite elastic in these children. And when you have traction retinal detachment, if you're using a standard trocar insertion technique and you're pushing with a standard trocar that there's a sharp end, you risk injuring the retina. As you can see the video on the bottom left, you can see I'm having to push into the eye with the blunt-ended introducer. So you usually use a temporal approach, an endoscope. The reason for a temporal approach is because when you're having your meal with your utensils, you have your food in the center of the plate with your utensils in your right and left, whether it's a fork and knife or a fork and spoon. So therefore, the most of the traction is temporal. Therefore, we sit temporally and have the endoscope, usually in my left hand, the retractor in my right hand, and I cut between my instruments to optimize traction relief. To air tamper out is used at the end. So here are our results. This is to present our first 3 years of data, 57 eyes in 38 patients. We now have over 100 eyes, median follow-up of over 1 year. Median gestational age 25.7 weeks, median birth weight 740 grams. So majority was stage 4A and 4B. There was almost 16% that were 4B5s. The median age at primary vitrectomy was 44.3 weeks. In terms of primary anatomic outcome, so overall, there was 82.5% retinal reattachment rate. And as you would expect, in the less severe detachment cases, 4A, i.e. stage 4A, the primary reattachment rate was 92%, and then it reduces to 82.6% and 55.6% depending on severity of detachment. This is the most important slide of my talk, which is the primary lensectomy rate. In this consecutive series, we removed 0 lenses during primary vitrectomy. In terms of visual outcomes, 66.4% achieve fix and follow or better, with over 82% of the stage 4As achieving that level of vision, and we had visual acuity outcomes in 91% of patients. So if we look at data from the ET-ROP trial, that is now the standard of care, that has set the standard of care for laser treatment for ROP. You can see that even in the visual acuity outcomes essentially are not as good as what we have been able to show. And I feel that this is likely due to the fact that we're preserving all the lenses in these cases. There is in terms of the risk of complications, they're relatively low. In terms of the primary lensectomy rate, I wanted to compare against a couple of most relevant studies. You can see in our study of 57 eyes, not 51 eyes, we had 0% primary lensectomy rate, whereas in a study from Egypt and Michigan, in the second row there was 57% primary lensectomy rate, and then a study from UCLA, 31% primary lensectomy rate, all with lower retinal reattachment rates. Therefore, our technique, I feel, works very well for these high-risk babies. When should you refer an ROP retinal detachment case? Really at the earliest sign of traction, when there's early temporal vessel straightening, ideally before significant dragging, because dragging affects vision. And outcomes are better the earlier the stage, so stage 4A or 4B, and the less traction there is, the easier the access is into the eye. So in conclusion, lens removal during vitrectomy for ROP increases ocular morbidity, including glaucoma, aphakia, and amblyopia. And prevention is really better than cure. It optimizes outcomes, and therefore endoscopy combined with microscope visualization, which is the technique we use at our UK National Centre at Great Ormond Street Hospital in London, appears to work best and gives patients quite good outcomes. And in time, we will be able to share long-term outcomes because patients around the UK all come to our centre for long-term annual follow-up. Thank you for the opportunity to speak. I'm happy to take any questions.